on deep learning regression of cardiac phase from real-time MRI. This work was supported by grant funding from GE Healthcare, and senior author has property rights at Arteris, now acquired by Tempus. No other financial disclosure by other authors. The motivation behind this study is that Cine steady state free precession is the backbone of cardiovascular MRI for ventricular function and volumetry. Specifically, Cine steady state requires electrocardiogram recorded over multiple heartbeats, as shown in the top panel here. Electrocardiogram gating enables concatenation of images acquired at various phases of the electrocardiogram to create an overall image at that phase, here shown. This inherently leaves Cine SSFP vulnerable to arrhythmias and distortion of moving artifacts. Here A is shown in end diastole and C is shown in end systole, while the patient is having atrial fibrillation. This problem can be mitigated with real-time MRI, which does not use ECG gating or breath holding. However, real-time MRI is clinically not feasible for quantitative analysis of cardiac function. This is because cardiac phases must be identified from real-time SSFP, as most analytical models currently use cardiac phases based on RR intervals. Labeling cardiac phases manually by a radiologist is both time and labor intensive. Our proposed solution to this problem is a semi-supervised deep learning method to automatically identify end diastole and systole cardiac phase from real-time MRI across the left ventricular volume. To do this, we began with 241 patients who had short access Cine SSFP images available. Within each short access series, there were 20 cardiac phases of temporal steps, 37 milliseconds. The advantage of this is that the Cine SSFP were labeled for cardiac phase. Here, end diastole label signal is shown. To simulate real-time data, we downsampled spatially and temporally using the Fourier space and zero padding across it, as well as interpolating 10 times across the time axis. Here, this allowed us many frames to choose from, and similarly, to extend the label to those frames, we applied a temporal Gaussian convolution to give a probability estimate of how close to true end diastole these frames that were interpolated are. From there, we subsampled cardiac phases out of the new pool of data available with varying time step. Here 120 millisecond is shown, as well as subsampled corresponding phase labels from the temporal Gaussian convolved phase label estimates. The same process was repeated for end systole labels and end systole frames as well. We used this data to train an exception model with 3-channel input, each of the channels being a successive cardiac phase, and a final output in 2 separate channels, one for end diastole, one for end systole, each of which consisting of 3 probability estimate values. These probability estimate values were compared to the label with regression from the true label using mean absolute error loss. The data were split at the patient level in 80% training, 10% validation, and 10% test set. And of note are the augmentations, which were changing starting points within the 10 times interpolated data, as well as changing temporal step. End diastole predictions were averaged on a 3-frame sliding window, and the first derivative and the second derivative of that average allowed for identification of the end diastole frame that was closest to the end diastole label. Here, the second derivative was thresholded at a value of 0.45. The same method was applied for end systole labels as well. Testing on our test set, we were able to attain an accuracy of 0.905 and 0.877 respectively for end diastole and end systole with 0 frame distance at the exact label. And if we allowed 1 frame leniency from the exact label, this would be about 120 to 240 milliseconds, then the accuracy precipitously increased to 0.96 and 0.957 for end diastole and end systole respectively. Here, we are shown an actual real-time series with end diastole and end systole labeled by one of two physician scientists in training, as well as EKG recording, which was available. And this is across multiple slices. A panel of slice 3 has been zoomed in. Once testing our model, we see that the predictions and ground truth match up very well for end diastole and end systole in an actual real-time data set. In conclusion, deep learning enables automatic cardiac phase estimation of end diastole and end systole from downsampled Cine steady state free precession MRI within 0 and 1 frame distance. And this model is translatable toward end diastole and end systole identification from real-time SSFP data. Thank you so much for listening.